the neoadjuvant setting in triple negative breast cancer is a very important subject. And we know all that the pathological complete response is a very important issue. And it is important to, it is a surrogate for the outcome, including the disease-free survival and the overall survival. And because of this, a lot of effort done to enhance the pathological complete response in patients with triple negative breast cancer in the neoadjuvant setting, either by choosing what is the best ever chemotherapy and how to go for dose density or dose intensity, adding the platinum PARP inhibitors and the important player now, the checkpoint inhibitor. And going through the different data set and the publications in this issue, we choose usually to go for the chemotherapy, including the dose-dense regimen. So we have higher pathological complete response according to the meta-analysis. And also it is now, we agreed even in the consensus of the BGICC last year to add platinum to the neoadjuvant setting in patient in the neoadjuvant setting in the patient with triple negative breast cancer. And one of the important thing is the checkpoint inhibitor that we know in the Keynote 522 that we have better pathological complete response in addition of the pembrolizumab in the neoadjuvant setting. There is some contradicting results in the new TRIPS trial, but in the consensus panel, we have agreement that we can use the immunotherapy in the neoadjuvant setting in high-risk population to have higher pathological complete response. On the other hand, there is a trend for response-adjusted treatment or descalation process. Can we go for descalation in the patient with triple negative breast cancer? And the answer is yes. We have the small tumors less than 5 millimeter, and even in T1B tumor that we have a new publication that the breast cancer specific survival is not changed with the addition of chemo or not to give chemo. And also we can give a carbo containing regimen without the addition of anthracycline, and then to assess the pathological complete response. If in the patient achieving pathological complete response, the addition of anthracycline is later not affecting the survival. So we can go for those response-adjusted regimen in the patient with triple negative breast cancer. I think the neoadjuvant settings in the triple negative breast cancer is very, very hot. And I think these subpopulation of breast cancer need more and more investigation to have better chance for cure.